files. Last time we learned about an atypical case of diabetes which was related to lipodystrophy rather, and there was an interesting discussion related to that, when to suspect lipodystrophy and how to treat those kind of patients. Today we are having a case discussion that is related to hyperglycemia associated movement disorder, I think, which is something new which we are going to hear in today's case file. And I think second year DM resident will present a case. Already they have published a case series related to the same, and there will be two neurologists, and our patron Professor A.K. Das probably will join in few time. So I will hand over to Dr. N.K. Singh for further proceedings of today's case file. Dr. N.K. Singh.
Thank you, Dr. Jetwani. As Dr. Jetwani has already introduced that the RSSDI National has started a case file series, and today's episode will be really very, very interesting. So I think our three panelists, Professor A.K. Das, he may join anytime. As I think everybody is aware that he is the topmost endocrinologist from the Pondicherry and scientist and a new medical center at Pondicherry. He is the patron of the RSSDI, and he has so many credits in diabetic field. Everybody is aware. So when we will welcome when he joins. Next, welcome Dr. Souvik Dubey. He is DM Neuro, as you are seeing here, and he is currently appointed as Assistant Professor, Department of Neuromedicine, Bangalore Institute of Neuroscience, IP GMER and SSKM Hospital, Kolkata. He has more than 150 publications in journals of national and international repute, and so many citations. And his area of interest is cognitive and behavioral neurology, neuropsychology, movement disorders, myomia, angiopathy, and central demyelinating diseases. So welcome you, Dr. Souvik. Happy to see you here. And next, Dr. Sarika Patil. Can you display the, so see the MD internal one thing again, DM neurology and fellowship in the movement disorders, consultant neurologist and movement disorder specialist experience from the Rajkot. He has so many vast experience. Now is assistant professor, Department of Neurology, the JJ Group of Hospitals and Grant Medical College, Mumbai, and associate consultant, Department of Neurology, and full-time consultant, neurologist and movement disorder specialist, that is the SCG Hospitals, Rajkot, Gujarat, from 23rd of June 2002 to 16 July 2021. Full-time now consultant neurologist and movement disorder specialist at Sterling Hospital, Rajkot. So I think a great thing that he has done his fellowship. And today's speaker, till now in our previous episodes, all the reputed persons from the field of diabetology from the pan-Indian level. But today, this will be the first time that we are going to introduce you Dr. Subhankar Chatterjee, a second-year resident of DM endocrinology at Kolkata. He has not written anything more, but he has published so many papers. So I think Dr. Subhankar Chatterjee, please share the screen and proceed for the caseage.
Yes, sir. My PPTs.
Yeah. You share the screen first. PPT, would you share or I have to share?
Sir, please share.
Oh, I have to share.
Yes.
Let me see. If you have not any, just let me see if I have on my WhatsApp.
By the time Dr. N.K. Singh will share the screen, I think this is an interactive case-based discussion. Anytime Dr. Souvik, Dr. Sarika, Dr. Sanmugavelu, if you like to make any comment or any question, Dr. J.K. Sharma has also joined. Thank you, sir, for joining. So anybody can make comment or can ask question in between so that we can have a lot of interaction related to the same topic.
I think slides are visible, sir.
Visible. Yes, sir.
Okay, so everyone can see the slides.
Yes,
So I
sir.
will just
Yes, sir.
Make it
Yeah.
slideshow, sir. Good evening.
good.
Yes, this is okay.
So Dr. Subankar, you can start now.
Yeah, sir. Oh, thank you, sir. Today I am going to present on hyperglycemia related movement disorders. Thank you, sir, for inviting me. Each and everything about this disorder has been taught by none other than Dr. Shobik Dubey, sir, by me. So I am indebted forever to him. Now, please. Now, we are starting with a case. 52-year male, office clerk, never screened for diabetes, hypertension, or thyroid disorder before, presented with acute onset hyperkinetic movements involving the left arm for the last 5 days, which only disappears during his sleep. Now, please see the movement. Predominantly proximal, predominantly distal involvement, upper left arm, semi-pervasive swinging motions. So, semiologically, it was ascribed to hemichoria. Now, he had no previous history of movement disorder, no family history related to movement disorder as well. CT brain was done from outside. That was unremarkable. BP was normal and no other focal deficits except these abnormal movements. Now, what you will do next? Now, we see that CBG is, that is capillary blood glucose random, was 459. ABG turned out to be normal. There was no acidosis, and the blood ketone level was 0.2 millimole per liter. That is negative for ketone body. And HbA1c was turned out to be 15.1%. Now, the MRI is here is being shown. The MRI shows the striatal hyperintensity contralateral to the affected site. There is a clinically affected site, and it is hyperintense on T1. This lesion was not visible on CT before. Now, straight away, hydration and insulin infusion was started to achieve normoglycemia.
I think, yeah, Dr. Subankar.
Yes, sir.
Hello. I think
Yes,
we will stop here for the discussion.
Yes, sir.
So,
yeah.
So here is a patient which has got a 459 milligram per DL, so high sugar, but with this movement disorder. So how to proceed for that? What did you think when you got this case? What could it be? Is it a neurological case, totally neurological, or it is the hyperglycemia related?
Sir, this is a purely hyperglycemia related finding was there, and the thing is that only hyperglycemia can cause this kind of dramatic movement disorders, acute onset, de novo, which is actually completely reversible by only treating the hyperglycemia, was known since 1960, but probably we are not very much aware of it because there was not many publications regarding this, and still now, surprisingly, no diabetes textbook, even medicine textbook, does not specifically talk on this disorder. So, but very interestingly, the most common cause of acute onset hemichoria or hemibalismus in acute setting is actually hyperglycemia. The most common metabolic cause is hyperglycemia. So the catch point is that it's a very classical case. The most common phenotypic presentation of hyperkinetic movement disorder related to hyperglycemia is hemichoria or hemibalismus. So whenever you get such a prototype case, always the practice is that always check for a capillary blood glucose instantly before referring the patients to neurologist or before going into the thinking about the more rarer causes or going for the neuroimaging. Even in the distant place where the neuroimaging is probably not available, but glucometer is available there. So please do not forget, even from primary care physicians, the message is that do not forget to check a CBG whenever you find acute onset de novo hyperkinetic movement disorder.
I think
Sir.
I will request Dr. Souvik Dubey to explain more. Do you think that this is not a pure neurological case, but rather this only happened when patient develops such a high blood sugar? Dr. Souvik.
This is very pertinent question, sir. This is very pertinent question. The most important aspect in my sense is that acute onset. The problem with the striatum means other diseases, other etiological causes of basal ganglia and striatal involvement, like vascular etiology, like stroke, demyelination, and other etiologies, metabolic disease, that may produce some sort of abnormal movement disorder, but not in a very, very acutely. So what we observed in our day-to-day practice is that, but a stroke and vascular lesion, stroke involvement of the basal ganglia can lead to movement disorder, various kind of movement disorder. But in that case, they usually starts after the improvement of that hemiparetic side, and it's a pure basal ganglia stroke even. To our what we observe, that particular movement disorder presentation in even in vascular event is quite rare. But during convalescent phase or during improving stage, that may appear. But in that cases, hemichoria and hemibalismus among these two classical movement disorder of diabetic striatopathy, hemibalismus is particularly common in vascular lesion where it involves the subthalamic nucleus or like that. But what we get usually more in basal ganglia stroke is that dystonia kind of movement disorder. Number one. Second, that in metabolic disease, neurometabolic disease, heredoneurometabolic diseases like Wilson disease, NBIA, and other deposition disorder, which also have characteristics T1 hyperintensity in MRI, that may lead to the various kind of movement disorder, but again, subacute and incidence of chronic. So in this age group, in the presence of hyperglycemia, if movement presents acutely, then at least we should have to consider that serum CBG level should be monitored first, and it could be hyperglycemia related movement disorder in my sense. Sarika madam will highlight, I think, much more on this issue. So
yes, sir.
Yeah, Dr. Sarika, please.
Yes, sir. So I completely agree with Dubey, sir. So neurology, anything happens suddenly, there are few differential, as sir said, one of these is a stroke. But as he correctly said, stroke, they usually have a weakness initially, basal ganglia stroke, and there's a delayed movement disorder. So whatever present very suddenly, this high chance it's hyperglycemia related. I want to just add, in this particular case, semiology was, phenomenology was very clear. This large amplitude movements, involuntary movements affecting upper limb more than the lower limb. So it was very clear to know that it is a chorea, but sometimes this hyperglycemia related movement, they can start with just subtle chorea, or later it can progress to lower limb, or the balism component may come later. So in that case, with hyperglycemia, which it is rare, but another differential we should consider, sometimes this EPC is confused with this epilepsia partialis continuous. There is a motor seizure, patient is totally aware and conscious. So if the semiology is confusing, that is another reason the hyperglycemia related seizure the patient can have. Means there the capillary blood glucose is also high. But again, the clinical phenomenology is very important. If it is clearly hemibellism, hemichoria, large amplitude, then as sir said correctly, it is very high likely it's related to the hyperglycemia. There is no much more differentials. If the semiology is
I think,
yes.
Yeah. At this junction, I think
Can I ask a very simple question? Can it be because of electrolyte disturbances or hypocalcemia or something like that? Can it lead to this kind of movements?
Yes, sir. Electrolyte like hyponatremia, many electrolyte disturbance gives the movement disorder, but they are usually like they will have a generalized myoclonus, generalized tremor. This particularly unilateral thing means anything neurology we get one side, we suspect some structural disease. Purely metabolic, we have a generalized presentation. So
Sir,
such a typical phenomenology, sugar we should check immediately. Yes.
Yeah.
Sir, I totally, sir, agree with Madam, Sarika Madam. As because the first, even the movement semiology, before identification of the movement semiology, this is very much important to exclude the motor seizure, partial motor seizure. And this is very much common what Madam told that epilepsy partialis continua is much more common in hyperglycemic state. And the presentations are usually the tonic-clonic movement involving one half of the body and again present hemi fashion. So in any sort of movement semiology, you have to first exclude EPC before going into any particular types of the subtypes of the movement semiology. I'm totally agree with Madam.
Yes, sir. Yes.
Yeah, so I think now I will proceed for how Subankar, how you treated this case. Tell.
So
NK, I have one doubt. Can we say acute? We say acute striatopathy in a patient with diabetes? Striatopathy in a patient with diabetes. Acute.
Dr. Dubey.
Yeah. Sorry, sir. I cannot get your question, sir. Please repeat, sir.
Can we say patient has acute striatopathy in a diabetic patient?
Sir, it's a very good question, sir. This is the problem is that even after thorough search of the pathophysiological model, how striatopathy and striatopathy related movement disorder occurs, it is still very unclear that whether it's the chronic hyperglycemic state that is responsible or it's the acute fluctuation. That means sudden raise of the blood sugar on the backdrop of the chronic hyperglycemic state will give rise to this sort of movement disorder. This is still not very much clear, sir, from pathophysiological background. But if the presence of acute onset movement disorder, we can call it, sir, acute striatopathy, because we can also see that in chronic hyperglycemic state, usually patient presents with some sort of hypokinetic movement disorder, and we have in our case series 2 or 3 patients of Parkinsonian phenotype and sudden slowness, acute onset slowness of the movement in chronic hyperglycemic state. But it's the acute movement disorder, usually acute striatopathy, what you told, sir.
Yeah, so Subankar, please proceed now.
Yeah, sir. So our first goal was to treat the hyperglycemia aggressively. So, and as expected, but it is very dramatically as well that abnormal movements disappeared after CBG brought down to around 250 over 12 to 16 hours. And after that full evaluation to look for the other chronic complications, particularly retinopathy, nephropathy, and neuropathy was done. And patient was discharged with only the OAD, sulfonylurea, metformin, and 1-gliptin. And no recurrence of the symptoms, nearly followed up for 1 year. MRI done after 3 months found no striatal stigmata. That is, though the T1 hyperintense, striatal hyperintensity was completely abolished in next 3 months. Now we are now going to discussion on the movement disorders in diabetes. Movement disorder in diabetes can actually occur in 4 division. Can it be due to chronic diabetic complications like vasculopathy, like vascular Parkinson, that is mainly affecting the lower limbs, that is called, we call lower body Parkinsonism. And another is neuropathy, that is we call it PLNP, that is painful limb and moving toe, and also RLS. It is actually the complications of the diabetic neuropathy. And another more common is due to diabetic nephropathy during ESRD, uremia, metabolic acidosis, dyslipidemia. More often than not, patient presents with the myoclonus, and also few patients have Parkinsonism. Now, another is that hyperglycemia. Hyperglycemia also is there, can present with a PED or urea, and some cases, movement disorders can have syndromic. That is, they can present like Friedreich's ataxia, aceruloplasmia, ataxia, some gap positive, sick person syndrome, Bardet-Biedl or Wolfram syndrome. They have a phenotype of both diabetes and movement disorders. They are rarer thing. Now, today's our main topic of discussion is the acute onset de novo movement disorder due to hyperglycemia. Now, they can be broadly divided into two groups, cardioballistic or non-cardioballistic. The two we have divided into two groups because the cardioballistic is the more prototypical or more common movement semiologies. Now, around 60% of all movement semiologies are actually attributed to the cardiovalism. They can be hemi, mono, para, or generalized, or some component of dystonia like choriodystonia or chorioarthritis may also be present. Other than that, there can have myoclonus, various types of myoclonus, including focal, axial myoclonus, diaphragmatic myoclonus, obstacles myoclonus, dyskinesia like PKD, PNKD, or PED, orolingual dyskinesia, tremors, hemifacial spasms, Parkinsonism, dystonia, restless leg syndrome, blepharospasm, ataxia, etc. Now, first we will discuss on the cardioballistic movements in diabetes. Then we move forward to the other types of movements. It is first described in 1960, and since then nearly 200 cases have been reported till date and have been known under various terminologies, including hyperglycemic, non-ketotic hemicodia hemimalism. Some call it chorea hemicodia associated with NKH. Some call it only diabetic hemimalism hemicodia. Some call it chorea hyperglycemia BG syndrome. Now, in 2009, actually, the term diabetic striatopathy came up. Now, please see this movement. The very large amplitude fringing movement, that is the first one was upper limb, right upper limb monobalism. The next one is right lower limb monobalism. Similar case, but with different semiologies. Pure balism. The lower limb monobalism is actually much rarer. So I have kept this case. So we are moving forward, sir. Now, diabetic striatopathy was introduced this term to ameliorate this lot of heterogeneous term, and it is right now it's a pretty standardized term. Diabetic striatopathy.
Suvankar,
yes,
so
yes.
Please just let us elaborate on the two cases. So whether the blood sugar, what was the blood sugar in first case and the second case, just you showed?
Sir, both were non-diabetic but non-compliant. As far as I remember, the case actually, first case came to the Bardhaman Medical Hospital, in emergency, patient presented with this kind of movement for last 10 days, and the CBG came out with more than 500. And that the patient was admitted and was treated only with insulin and hydration. Patient got all the movements were reversed by next day. And then the next patient, the lady had a lower limb monobalism, and this patient was also non-diabetic, and this is actually a case from Dubeser's own clinic, and he visited neurologists for this sort of problem, ignoring her own diabetic status. She was completely she known that she was diabetic, but did not take up any medications for last more than 2-3 years. And she came with this kind of movements, and finally CBG was found out to be more than 400, I guess. And
so Dr. Sarika, let Dr. Sarika respond. Can I just take a take-home message here that having a high blood sugar, presenting with such movement disorders, you bring down the blood sugar to a normal level, and the movement goes away. So is it okay?
Sir, this as a treatment wise.
No. Suppose this is this is a clinical indicator also that hyperglycemia is doing this movement disorder. It is not an pure neurological issue, but rather hyperglycemia induced problem. And once you are treating or managing the hyperglycemia, then this movement vanishes, or you can bring it to the normal position. So I think it happens always, or in only some cases.
Not always, sir, but most of the cases with insulin administration and hydration, slowly the movement go away. Means it takes some few days to few weeks, averagely like month or 2 months. And few cases they need other medicine, symptomatic treatment to control the chorea and hemibalism, and they may take little longer time, but like Dubey sir can add, around 60-70% cases they respond, or we can manage with insulin like sugar control and the hydration. Few need the dopa blocker or other therapy. We will discuss further the treatment part, but it's not always case ki you correct the insulin, the movement will go away. It's not always. Sure. They take little longer time.
Yeah, what's your experience?
And there are sometimes totally agree with madam, sir. Totally agree with madam. Basically, majority usually respond with insulin only. But particularly if the movement semiology is hemibalismus, then we observe that it will take much longer time than other sort of movement disorder to disappear. And most of the time, they usually require the D2 antagonist to control the movement semiologies, and it gradually fades away for a period of 2 weeks to 3 weeks, like that. But other kind of movement disorders such as hemifacial spasm and pure chorea hemifacial spasm, they usually respond much better way compared to hemibalismus, and they usually respond more with insulin alone. But in case of hemibalismus, what madam told, that they usually take supportive drug therapy along with insulin and hydration.
Yeah, thank you. So, Subhankar, you proceed.
Yeah. So, diabetic striatopathy has been defined as either both or either one of the two following conditions. That is clinically acute onset choreovalism and striatal hyperdensity on CT or striatal hyperintensity on T1 weighted MRI. So there are actually various heterogeneity regarding this. So we have come up with a classification system of how to classify this diabetic striatopathy. We'll again we'll come back to the slide. We're just reading it for time being now. It can be symptomatic DS, it can be clinically isolated DS, or it can be radiologically isolated DS. Now, symptomatic DS can be concordant or discordant. Concordant means the lesion in the neuroimaging is contralateral to the side of the movement disorder. That is the right-sided chorea, left-sided T1 striatal hyperintensity. No problem with that. But there are many more discordance. So, what kind of discordance can be there? Number one is radiological lesion on the same side of the movement disorder. That is radiological lesion ipsilateral to the movement disorder. Radiologically unilateral lesion, but phenotypically bilateral movement disorder. Radiologically bilateral lesion, but movement disorder is unilateral. So these are discordance, clinical radiological discordance. Other can be clinically isolated DS, no radiological involvement at all. And another much rarer entity is radiologically isolated DS. Now, as we say that the magnitude of the problem, there is no very vast epidemiological data till now. Only 3 epidemiological data is there. One from Israel, all retrospective study from the prior hospital database. In Israel, it has been found that 1.2% cases can have diabetic striatopathy among the patients who are uncontrolled diabetic and also had sort of neurological illness. In Mayo Clinic, they have in US, they have said that 1% cases prevalence can be 1%, and in Italian studies, it is much lower, that is 0.16% among the cases who are diabetic, who had HbA1c more than 8%, and obviously with available neuroimaging data. Now, as I initially mentioned that the most common metabolic cause of hemichoria or hemipalismus is hyperglycemia, specifically non-ketotic hyperglycemia. So, very important to check for a blood sugar whenever a patient comes with hemichoria or hemipalismus. Now, in our series, we have actually screened 552 patients over nearly 7 years, and we actually have found that new onset movement disorders, patients with new onset movement disorder, or its mimics, as Sarika Madam said, its mimics most commonly the EPC. The 17.4% patients were actually diabetic, and among all the patients who had acute onset de novo movement disorder, 30% patients actually had non-chorioballism, movement disorder other than chorioballism. That is, they were not classical DS. They are non-DS patients, non-diabetic striatopathy patients. Now, if you see the global epidemiology, sir, please move the slide forward. Global epidemiology, we have found that Asian countries reported the maximum number of patients in China, South Korea, and India. Some cases from the Europe and Americas as well. Now, why Asian? Why Asian? Now, it cannot be explained with only the total number of population, because Taiwan much smaller country, and Japan as well. So, how they have overtaken the number in numbers compared to China, India, or America, and maybe Asian population may have some genetic predilection, and also maybe poor glycemic control among Asians, but not a very strong statement. And another theory coming up in very recent articles that maybe greater TP glycemic excursion in the Asians that is causing this kind of delta change in CBG post-prandial. That's why they are having this kind of movements. And the most plausible thing that I believe that underreporting from the West due to lack of awareness from physician is probably the most prominent cause of this heterogeneous epidemiology. Now, the mean age of onset of this disease is generally 6 to 7 decades, although as early as age of 8 years to as late as 90 years have been reported. In our case, in our series, and also some short case series from South India, they have also found little bit earlier age of onset of striatopathy, that is the 5th decade. That earlier presentation might be due to earlier onset of diabetes or earlier onset of the vascular complications, other vascular complications. Now, sex differences, the female predominance nearly 2 times, exactly 1.76 times in a big meta-analysis in 2020. But our case series actually found nearly the same male-female ratio. I don't know actually why we have had such finding. We did not have female predominance in our series. And the reason of female predominance is also not clear in previous series as well. The reason, some have postulated that increased sensitivity of the D2 receptors in the striatum in the estrogen deficient postmenopausal women is actually causing this kind of hyperkinesis. Now, type of diabetes, type 1, type 2 diabetes is most commonly reported, and type 1 diabetes has also been reported in few cases. Now, this case is very interesting case. This patient had a hemifacial spasm, and this patient actually found out to have diabetes, and interestingly had type 3C diabetes, lots of calcifications in pancreas, and also pancreas was atrophied. Patient needed insulin, and with insulin treatment, patient completely reversed this kind of movement, hemifacial spasm. This is another non-choreo, non-ballistic movement disorder associated with the acute hyperglycemia. Surprisingly, no one checked CBG. At least patients suffered for more than 2 years with this kind of movements. Visited multiple times into psychiatrists.
Shubhankar, with diabetes control, these movement.
Yes, ma'am. We also published this case, and probably this is the only case where type 3C diabetes was reported in association with the movement disorder. Yes, ma'am.
Yes. It's a rare case.
Yes, ma'am.
Because
Yes, ma'am. Yes.
hemifacial spasm is peripheral nerve hyperexcitability.
Yes. Yes.
Than the
Yes.
dystonia or
Yeah.
And yes, it's a rare thing. Yes.
Yeah. Now moving forward, the glycemic status. Long-standing diabetes, mean duration generally 10 years. These patients, poorly controlled diabetic, found the mean CBG in patients had like around 400, HbA1c 30%. But interestingly, it can be the presenting feature of previously undiagnosed diabetes. In the large meta-analysis by Chua, they have shown that 17% of cases had undiagnosed diabetes. In our series, 5% patients had undiagnosed diabetes. So thing is that when there is so much unawareness among us, unawareness from the patient level, social level, and also the physician level about diabetes, that patients with diabetes go unrecognized until and unless they come up with such horrible acute onset movement disorder, and they can be the
Vankar, stop. Vankar, just we will discuss the case here. So Judge Dr. Patil told that this was a very interesting case. Dr. Dubey, this presentation as a presenting feature of diabetes, I think Dr. Jetwani, have you or Dr. Tringwalu, do you have any come across such cases where this movement disorders, by movement disorders, you check the blood sugar and the first time it was detected? So Dr. Jetwani, what's your experience? Whether you have seen such cases?
I have not seen any case. This is something new which I am learning today.
So this is very rare, sir.
This will be much more common at a tertiary level center where a lot of such patients who are being roaming around with these problems and they present and then they diagnose to have diabetes. But I have not seen in my practice.
Yeah, Dr. Dubey, your comment?
Sir, what Sarika madam told, I'm totally agree with that point, that it is basically peripheral nerve hyperexcitability. That is the basic pathophysiology behind hemifacial spasm. Probably, I think that patient may have some sort of facial pulse on that side. And it is the chronic hyperglycemic state which actually aggravates. And as we observe in our day-to-day practice, that in degenerating phase of facial palsy, that may lead to different kind of facial abnormal movements, starting from synkinesia to hemifacial spasm. Yes. I think this case probably reflects that kind of movement disorder. What madam, what is your opinion? I think that is probable, one of the probable.
Yes, sir, I agree that's what I can think about the pathophysiology. That hyperglycemia giving to the hemifacial spasm, but very interesting. It went away with sugar control, so that correlate with
that part is very interesting.
Yes, sir. Yes.
But Suvankar, your series
insulin for that purpose, or giving oral drugs and controlling sugar over a period of few days will help, or you require insulin only for that purpose?
That should I speak?
Yeah. You tell.
The thing is that the patients with this kind of movement disorders mostly come with more than 300 blood sugar. It is not that patients does not come with 250. Even euglycemic cases we have also got few very rarely as well. But mostly they come with more than 300, 400 kind of blood glucose level. And also the thing is that the acuteness of the problem. It is the anguish that it is causing to the patient and also the family. So it is also becomes very much important to control it over a period of time. But here is also an important message now in new literature is coming up, that how fast we actually should control sugar in these cases, because in as we see cases of diabetic retinopathy in initial with very rapid strict control of blood sugar, the vision may deteriorate in some cases. Analogous to that, in movement disorder can also aggravate with too much aggressive control of blood sugar as well, because it is not the chronicity of the glycemic control, but the acuteness of the surge or acuteness of the fall. That is also important. So it is actually most classically in 95% literature, it has been written that control the blood sugar aggressively with insulin and hydration. But in there are newer reports, newer case reports are coming up when the movement disorder is actually manifesting when patients is becoming euglycemic, when patient is becoming near normoglycemia. So I will come up with those cases at the end of my presentation. But yeah.
Next.
I will like to add. So there are cases which are reported when they are treated with oral hypoglycemic agent. They took a longer time and there was a recurrence, means when we stopped the other chorea symptomatic treatment. So the control and the oral outcome is better if we treat with insulin initially.
Yes. So I think this case.
Yeah, this is another case, sir. This case is actually in the PG hospital where Dubey sir is working. The patient, this 62-year lady, came up with this kind of movement. I just requesting sir to move the slides. The two movements. One is the action myoclonus of the right hand with few monoballistic movements, and the right in the left hand there is diaphragmatic myoclonus.
Yeah, let the video to be played because people are interested in such cases. So this is really interesting again. So what do you think? This is a dancing belly in an old diabetic lady.
Yeah. Dancing belly is actually because just like a belly dancer, it happens due to the spasm of the diaphragm muscle. Diaphragmatic myoclonus is the main pathology here. And
I think you just end here. You just stop here again. I think this is an interesting case. I have never seen such case. Dr. Jethwani, whether you have seen or Dr. Velu, you have seen such cases?
No. I have not come across. No.
Dr. Dubey, what's your comment on this very interesting case?
I have seen a patient developing involuntary movement over abdomen, and she had a history of valve replacement and was on oral anticoagulants, and she developed embolic stroke, and that presented with involuntary movements over abdominal part. That was something like this dancing belly, but that was unilateral only and limited to one part.
So, Dr. Patel, what's your comment on this case?
Yes, sir. This dancing belly can happen because of, as in this case, diaphragmatic myoclonus or abdominal wall muscle dyskinesia.
Yeah.
Dyskinesia is involuntary movement, and that gives this appearance of dancing belly. And it has multiple etiologies. Like we commonly see, it's drug-related dancing bellies, abdominal wall dyskinesia. As sir said, sometimes any a stroke, like post-stroke movement as a part of post-stroke movement disorder, and this many metabolic disorders which can be multifocal myoclonus and multifocal movement disorder. If it affects this abdominal area, this can appear like those interesting dancing belly movements.
Yeah, Dr. Dubey, what's happened with this case? Because I think I'm saying your name here.
I want to experience of this case. Basically, sir, one evening, this case came to the emergency with the dancing belly, and we have searched a lot. What Madam told that we think it could be drug-induced dyskinesias or like that. We asked caregiver about what kind of basically I was there. I directly asking what kind of antipsychotic drug or any other drugs he is taking for last day, and any antacid like levosulfuride containing antacids he is taking or not. But actually caregiver denied that. After that, we went for a brain imaging to identify that whether there is any vascular lesion or not. Our peripheral pulse was absolutely normal, but again, then for a just routine purpose, I don't need any sort of extra credit because this was done, sugar level was done only as a routine purpose, and it came like 500, more than 500. And after starting insulin therapy and hydration, that dyskinesias and diaphragmatic myoclonus, whatever it may be, probably was diaphragmatic myoclonus, and that was totally went off the movement. And this movement was responded dramatically because within 36 hours, patient responded. and she blessed a lot to us.
So I think Suvankar, you will proceed here. But what I think here
this is
that
this is the
initially
case
diabetes was diabetes. Yeah. So
that
later we
shared
thought
with me in 2018, and this is the first case what I came back. Sir taught me this is the first case about this. And after this case, I myself got interested in this kind of diseases. Hyperglycemia.
So I think now the diabetologists should be very much aware about all these things. So initially the diabetes, as a diabetologist, we thought we are only dealing with sugar. Then this becomes that the cardiac equivalent. So we have to know much about the cardiac things. And then this came that this is also a renal but metabolic disorder. So we are also a specialist for the kidneys. And now I think that we should also take care of the neurologist for all these things. So that is actually really interesting. So Suvankar, you proceed.
Yeah. Sir, my next slide, and already I have discussed just before that some rare cases I am of delayed presentation of hemicardia in diabetic striatopathy and hemicardia hyperglycemia exacerbated during treatment of the hyperglycemia. And then on the next slide, classically, this movement is seen in setting of the non-ketotic hyperglycemic state. And it is said that ketosis is actually preventive into such movement disorders. The reason behind is that in non-ketotic state, the GABA level, the GABA is rapidly gets exhausted in non-ketotic state. Thus, the negative neurotransmitter in the basal ganglia gets depleted. On the other hand, the GABA can be resynthesized by acetate, which is adequately present in ketotic state. So in ketotic state, it is actually much more rarer to find abnormal movements other than non-ketotic state.
Yeah.
Moving forward, this patient, having said that it is classically seen in non-ketotic state, we have also found cases where the patients actually came with decay and this kind of movements. Please forward the slide, sir. They have the two cases. One is choleoballistic movement and another is fistulopathy myoclonus. This video is actually when I was posted in Dhanbad as a bonded SR post my MD. This patient came with this kind of movement along with this cachexia and all in severe dehydration and this kind of facial and upper limb movement, myoclonic movement. We have called it faciobrachial myoclonus. The CBG was nearly 400. The patient was actually came out to be a type 1 diabetes. We treated with intensively with insulin, and the next morning, the next video, please, sir.
This one.
Yes, sir. Right. Next video.
Just 1 minute. Sorry, just let me see. Suvankar, you can continue. There is some problem.
Yes, sir.
Let me again share the screen. There was some problem, technical problem.
Okay, sir.
Would like to. So your is it visible now? No. There is some problem with I think.
Your screen is now visible.
Yeah. I think I'm sharing again. Screen is visible or not?
Visible.
Yeah.
Visible.
Then I have to. Yeah, then I have to start the show from the beginning.
So now the slides. Yes.
Yeah.
Second, third. Moving.
Yeah.
Yes, moving.
moving. That facial. Dancing.
So here, Dr. Subhankar?
Yes, sir. No, sir.
So
Just before, yes, sir.
Yes.
Yeah. This 23-year-old male presented with this kind of movement disorder, and on retrospectively, the patient had osmotic symptom for nearly about 2 weeks. After referral from several hospitals, the patient landed up here with this kind of movements, this severe dehydration. Now, involvement of the body regions. So most commonly is arm and leg, as we see in the classical cardioballistic movement disorder, followed by arm, leg, face, isolated arm, leg, trunk, arm, face, and also the isolated face. Now, what about the bilaterality? Bilateral movement disorder can be seen in the 9.7% cases, actually for the diabetic striatopathy cases. That is the 9.7% of all cardioballistic movement disorder. But bilaterality was actually much more common in our series when we also included the non-cardiovalism as well. And actually non-cardiovalism was significantly more associated with the bilaterality than the cardioballistic movements. Now, so the key and the very important is that few physicians or few non-neurologists are maybe aware of that the non-cardioballistic movement disorders can be, the cardioballistic movement disorder is actually classically associated with the diabetes, but awareness about regarding the hyperglycemia associated non-cardioballistic movement disorder is much lower. That is reflected in this study, that the delay in diagnosis in non-cardioballistic movement disorder is much more than classical cardiovalism. So the point is that the hyperglycemia can be associated with the plethora of movement disorders, including the classical hemicardia, hemimalism phenotypes. And even if the patient, the caregiver cannot decode the exact semiology as trained neurologists can do it easily, but many physicians and non-neurologists cannot exactly decode the semiology. Even if they should measure a CVG fast, even if the semiology is unknown. Now, the next case is that, as Madam said, that most common mimic of diabetes associated movement disorder is EPC. Now, come to this case. This is also a case from Dhanbad. Now, when patient, this lady, nearly 82 years old lady, non-diabetic, completely non-compliant, presented with this kind of focal seizure, predominantly involving the left facial muscles and left periocular muscles. When the patients got treatment, now the CVG was nearly 500 or something. When the patient was treated with for this seizure and hyperglycemia, we also observed that patient had this kind of athletic movements in his right upper limb and also the right lower limb. Interestingly, this patient on neuroimaging, we found that patient had a completely left caudate head was completely atrophied, and we further reported this in the journal. Next, please. Next slide, please. Next slide, please.
Yeah, again, there is some problem with my, I think, Subhankar, there is some, again, I have to share. I have to again open the case. Let me see.
Yes,
there is some technical fault on my side. This is again, you told that this is a case from Dhanbad. So how you treated this case? In the meantime, I am trying to open your presentation. So how you treated and then how responded this case?
Yeah, I think the first message clear cut we want to give to every person who is listening to this is, any person presenting with abnormal movement disorder, whether they are diabetic or not, just check their sugar first.
Yes, sir. Yes.
If it is severely high blood sugar, it may be related to that. You have to keep that in mind.
Yeah. Yeah.
Yeah. So I think, do you about more cases or this is the end of case? Subhankar?
I think this is the end. I think this is the case. This is the end, sir.
I'm trying. Let us, Dr. Patel, can you comment on the last case? What happened? I'm trying to open the PPT, but anyway.
Yes. So I just want to ask Shubhankar. Initially there was partial seizure, and once it got controlled, then there was a movement disorder.
Ma'am, initially patient had concern regarding the focal seizure. So we all trainees and all interns were all attentive regarding that seizure only. But when the seizure got completely goes away, then our focus came that she continuously moving his right lower limb and right upper limb as well. More subtle movements, not hampering with her daily life, but as I already knew that this kind of movement is not normal per se, so I further investigated and further did a neuroimaging, and we find a caudate atrophy. Left head of the caudate was completely atrophied, and surprisingly, not surprisingly, as we actually expect that this kind of movement was actually not completely reversible with glycemic control alone, and the patient had to receive some kind of anticoria medications, and with that also it was only partially controlled.
Yes, so here in case this possibility, usually the diabetes is risk factor for stroke, and this atrophied caudate, maybe there is a gliosis, and that has given delayed movement disorder and the seizure, both can be explained. So if it is stroke related, it's difficult to control. Yeah, they
exactly.
Resistant to treatment.
Exactly, madam. Exactly.
In continuation of the madam point, we start that the association between the stroke and striatopathy in the next slide.
Yes.
Slides are visible now?
Yes, sir. Yes, sir. Please.
Yes,
please
sir.
Yeah, let me. So the slide is.
Yes, sir. Yes, sir. Please.
I think we'll get the slide. Yeah. Yeah. So you saw this or not? I think.
Yeah. Sir, just before, just one before, sir. Another one.
I think it's 9:25. We need to wind up by 9:35. Dr. Shubhankar.
Yeah. Yes, so Shubhankar, you have any case because
we are running short.
Yeah. So I will just so if there is any more case here, imagine it is being shown here. Yeah. So, do you have comment on this? Sir, this is classical imaging. Yeah.
This is classical of DS. In the left side, it is in the CT scan of one patient, and in right it is MRI of another patient. Yeah. One is left stratum, on the right stratum. The key message is that this in striatopathy, the lesion radiologically can be very much be misclassified as hemorrhage.
So what is this clinical pearl you can say here just in fast? What are these clinical pearls? So you are showing that no contributory imaging abnormalities in 56% cases and one choreoblastic. Yeah.
Yes. So
so this is important again, huh?
Yes.
So this is a pathological analysis. This is radiopathological continued. So we are just coming at the end with the message we want to say. So I think already this is, you can just conclude by seeing these slides. Conclude your talk, and we will discuss.
One slide prior, Dr. N.K. Singh, if you can go.
Yeah.
That is related to treatment and outcome. You can
tell about the treatment.
Yes, sir. The thing is that most cases are actually will respond with only intensive glycemic control and hydration, and nearly 50% of patients recover with this alone. And overall outcome in the literature is nearly about 76 to 100% recovery, and few patients may need additional therapy, as madam told. Then haloperidol, tetrabenazine, risperidone, or levodopa, depending on the movement semiologies. And successful outcome after using these additional anticoria drugs is may reach 76% as well. And for those rare cases, when medical therapy is not fully reverse the pathology, we can try the surgical approaches as well. Now, we see the recovery time is generally between the 2 days to 14 days. 2 days among those who are detected early, who are detected, who are treated only with insulin, compared to those who with advanced cases or may need additional treatment, they may need more time to recover. And also the recurrence.
I think, yes. Yeah, Subankar, you have just concluded. I think this is a nice presentation, very important message.
I'm done.
So, yeah, within next 2 to 3 minutes, I will take the take-home message from all our panelists, Dr. Souvik Dubey. Few questions which has our people will like to know that how common it is, because in one series, Dr. Subankar thought that it could be the 5% cases, maybe the presenting feature. The movement disorder could be the presenting feature of new onset diabetes. So this is very important again, that we should be very vigilant on that. And whether it is more common with acute or chronic uncontrolled cases. So I think the message is it comes with acute cases. Or suppose a patient is uncontrolled diabetic case, or sometimes goes in a stress and gets more hyperglycemic episodes, then this could occur. Because I have also seen a few cases, but it took at least, I think, 2 to 3 days to control these movements. So what are the most common movement disorders that you can say? But what is the important point is why only few persons develop it? Can you say that not all people present with that? So what are the reasons?
Sir, my final take is that for acute onset movement disorder, we should check CBG. This is my first take. My second take is ureoballistic movement is the most common sort of movement abnormality associated hyperglycemic state. Number third take is that it's the chronic, poorly or uncontrolled diabetes on top of acute fluctuation, which is chiefly responsible for acute onset movement disorder. And number fourth is that the real gray zone, why Asian and why females? This part I really don't know. Probably some ethnic background and some genetic factor may have some role to play, but still needs some sort of focused research on it, that there may be any sort of genetic factor or ethnic variations. These are my final takes, sir, for all sorts of abnormal movements starting from EPC to choreobalism, even non-choreobalistic movement. We should check CBG for early diagnosis of movement disorder related to hyperglycemia.
I think very important point. Dr. Sarika, your take-home message for our audience.
Yes, sir. So I absolutely agree with all the points of Dubey, sir. Just to add, as already discussed, this acute onset movement disorder, checking sugar is very easy in emergency. Go for that. I agree that no need to go for imaging. First, control the sugar, but every patient should be imaged. Even if the movement are controlled, we should have one imaging of every patient, preferably MRI, because the sensitivity is high. And if there are other etiologies, we are able to pick up more on the MRI. Other thing, treatment-wise, most of them will respond to the sugar control. But few of them, in my experience, as I practice movement disorder, maybe there's a referral bias. But there are few cases who need longer treatment with dopamine blocker or depot-depleting drug, some SSRIs or clonazepam. And there are, I have seen there's a recurrence after reducing this dopa blocking drug, even the sugars are controlled. So I suggest start low, this dopa blocker drug, and go slow. Because in this, these are usually elderly patients. If you and these movements are very dramatic and disturbing, this large amplitude. So we are compelled to treat it promptly. I'm talking about this small group we are difficult to treat. In that case, we should not go with higher doses of dopa blocker, particularly a typical one, because there is another entity. It's a tardive syndrome, that is a drug-induced movement disorder, which are common with dopa blockers, atypical. And if there is an overlap between this tardive and this resistant hemivalism, hemichorea, then it becomes very difficult to treat. And plus this drug are sedative, this elderly patient, if they are sedating, that can cause the various complication. So yes, correctly said, this suspect promptly in emergency, the sugar checking and the control of sugar is the key. Yes.
Excellent. Dr. Vellu, can you give some your take home?
Before that, I need one question. Have you reported, have you come across rubral or cerebellar tremors as a movement disorder?
Yes, sir.
Because
yes,
we have been talking about basal ganglia.
Correct.
Yes.
So hyperglycemia related rubral tremor, they're rare compared to choreoballism, but yes, this I think wide variety of movement disorder, as Dubey sir said, myoclonus, tremor, ballism, chorea, and this new thing, this hemifacial spasm. So multiple tremors, particularly if the diabetic has underlying renal dysfunction, this wide spectrum of hyperglycemia related movement disorder, we can say. And there's another thing what I've seen, this hyperglycemia related who has the vascular insufficiency in basal ganglia, those they are difficult to treat with sometimes with this mixed pathology.
Yeah.
So diabetes causes vascular changes.
Yes.
Excess metabolic changes.
Chronic ischemia.
Metabolic changes.
Plus,
so Indian
yes,
phenotype we know. On the top of retinopathy, neuropathy, microalbuminuria, we should always keep our mind on the movement disorder, which is most often self-limited and prognostically favorable, and less often need a treatment for a shorter period of time.
Correct.
Excellent. So I think Dr. Jetwani, we have come up to the end. So can you propose a vote of thanks with your take home?
I think the message is very clear. Any patient coming to emergency with any kind of acute movement disorder, check sugar. That is priority. That is on a priority basis. Don't go for,
absolutely,
because generally the people, they start sedative and other thing and they try to shift patient for imaging. That is the priority. But just first check their sugar. If sugar is high, control it. Do imaging. We don't say don't do imaging, but you can first control this thing. And if it is related to hyperglycemia only, most of them will respond to that thing. And then you can go for imaging to find out the structural lesion. I thank Dr. Subhankar for preparing an excellent presentation related to this variety of cases, giving us an insight of what can happen with hyperglycemia as far as acute movement disorder is concerned. Dr. Shauvik Dubey, who has published a nice series, and for his comments, and Dr. Sarika for contributing as far as acute movement disorders are concerned. And thank you also Dr. Sanmugavelu for joining and Dr. N.K. Singh for chairing the session. Thank you. We missed the presence of Professor A.K. Das. I think he's busy somewhere. He's not picking up phone. So next time again, Dr. N.K. Singh, we will involve him in one of the RSSDI case files.
Yeah.
Okay. So thank you everyone for joining.
Yeah.
We will again meet next month, probably in this third week of every month, Friday evening, 8:30 to 9:30 p.m. with another interesting case related to diabetes or hyperglycemia. Thank you. Good night.
Thank you.
Thank you.
Good night.
Thank you.
Good night.
Good night. Good night. Good night. Good night.
Very good session. Yes.
Good night. Good night to you all. Good night.